Hello, and welcome to Montana State University College of Nursing Center for Interdisciplinary Health Workforce Studies fall webinar series that focuses on the state of the primary care workforce and how nurses can help improve the delivery of primary care. We are pleased to have all of you joining us for today's webinar. My name is Christy Friedman, and I'm the program manager for the center. A few center announcements before we begin today's webinar that focuses on the transforming role of RNs in primary care. First, we have posted 2016 third quarter RN employment trends to our website. Total employment of registered nurses continued to increase at a brisk rate in the third quarter of 2016, and employment increased in both hospital and non-hospital settings, and we also observed a sharp increase in employment of younger-aged RNs. We encourage you to visit our website for further information. Second, some of you may have attended our webinar last month discussing the Macy Foundation's 2016 conference report on registered nurses, partners in transforming care. We encourage you to read the report, and if you missed the webinar, we have the recording for you to listen to available on our website. You will find that under the Video Library tab. We also have new RN regional forecasting research posted to our website titled, "How fast will the registered nurse workforce grow through 2030? Projections in 9 regions of the country." That is available on the online version of the journal Nursing Outlook and will be published soon in hard copy in the journal. The purpose of this study was to understand how the outlook for growth in the future number of RNs over the next 15 years varies regionally across the U.S. We apply our nursing supply model to 9 U.S. Census divisions to produce separate supply forecasts for each region. We find dramatic differences in the expected future growth of the nursing workforce across the regions. Visit our website for a direct link to the online article to read more. And finally, I know Christmas is fast upon us, but it's not too early to be thinking about summer 2017. Save the date and make plans to attend the 2017 National Forum of State Nursing Workforce Centers Conference titled The Nursing Workforce and Health Reform, Trends and Opportunities in a New Political Era. This conference is being co-organized by our center and will be held June 7th through 9th at the Grand Hyatt Denver in Denver, Colorado. More details, including call for abstracts, sponsorship, and registration information is coming soon. And again, please visit our website for this and more information at healthworkforcestudies.com. After today's presentation concludes, we will have 15 to 20 minutes for discussion and questions and answers. Please feel free to type any questions you have in the area designated for questions on your menu bar, and we will get to as many of your questions as we can. We are also recording the webinar today, and we'll have it posted to our website. We have posted all of the previous webinars to the website, so if you missed any of our previous ones, you can find them there, and you can also find many presentation slides for some of the events as well. Now, I would like to allow Peter Bierhaus, Center Director, to take a minute and introduce our speakers. Peter?
Hey, thanks, Christy. Well, hello, everyone, and welcome. I'm out here broadcasting from Bozeman, Montana, at Montana State University in the College of Nursing. We've got snow on the ground, and the bears are hibernating now in their dens, and people are getting ready for the ski season. So holiday season's in the air, and students are very much aware of final exams coming up. But anyways, given that, I wanted to just sort of mention something that Christy talked about a few minutes ago, noting the webinar that our center organized back in October, in which we had Dr. George Thibault, Diana Mason, and Tom Bodenheimer on to explain the reasons for the problems in primary care, how the nursing profession can be helpful in overcoming these challenges, and ultimately to discuss the Macy Conference report and the recommendations that came out of that report. Now, today we're going to be building on that report by providing an example of what might primary care look like going forward using registered nurses and others to provide these needed services. So with that, I'd like to just quickly introduce our two presenters today. First, Dr. Margaret Flinter. And Margaret is the Senior Vice President and Clinical Director of the Community Health Center, which is a statewide federally qualified health center serving 150,000 patients from its primary care centers in the state of Connecticut. Margaret is well known for leading primary care practice transformation initiatives across the country for many years. Now, Margaret is also a family nurse practitioner, and she's held progressive roles in this particular organization as both a primary care provider and the executive leader of the Community Health Center, and has transformed this clinic to one of the largest and most innovative FQHCs. In 2007, Margaret founded the center's Weizmann Center for Innovation. Now it's called the Weizmann Institute, which is a center devoted to research, innovation, and quality improvement. Margaret also serves as the National Co-Director of the Robert Wood Johnson Foundation's primary care teams, specifically Learning from Effective Ambulatory Practices, the LEAP project, which is studying exemplar primary care practices across the country. Dr. Flinter has led national development of a model of postgraduate residency training programs for new nurse practitioners and established the National Nurse Practitioner Residency and Fellowship Training Consortium as an independent organization to serve as an accrediting organization for such programs. So Margaret has done a lot to contribute to primary care, and I'm only highlighting half of what I could, but I did want to just note that since 2009, Margaret has co-hosted a weekly radio show called Conversations on Healthcare, which connects people with issues of health policy, reform, and innovation, and speaks widely on topics related to primary care transformation. So a lot going on with Margaret, and we're delighted that she will be one of our presenters. Now, Margaret's going to be joined by Dr. Mary Blankson. And Mary is the Chief Nursing Officer for the Community Health Center. And Mary oversees a diverse set of nursing services across this network, including primary care, health care for the homeless, and school-based services. Now, as the Chief Nurse Officer, Mary ensures the quality and the expansion of nursing services, the development of nursing policy and continuing nursing education aimed at enhancing the team-based care model. She collaborates extensively with their Chief Medical Officer to ensure the standards are met, compliance with Joint Commission and Patient-Centered Medical Home, etc. She also works closely with the Chiefs of Behavioral Health and Dentistry to promote interprofessional care that supports the successful integration of multiple disciplines for team-based care. And again, I could go on about Mary, but let me just conclude by noting that Mary served as a preceptor for America's first family nurse practitioner residency training program at the center in Connecticut. So with that, let me turn the microphone over to you, Margaret, and take it away, and we'll talk to you in a little bit.
Perfect. Well, thank you, Peter. Thank you, Christine. And Mary and I are both delighted to be here with all of you this afternoon. We know what a commitment it is to take time out of your busy schedules, and we are going to jump right in so we don't waste a minute of that time. I think I might have retitled this presentation, Mary, as Welcome to the Year of the RN in Primary Care, because between the work of the Macy Foundation and the tremendous resources they've devoted to looking at nurses as part of the transformation of primary care, the work of the LEAP project and some of the research that's come out of that, the new publications that are out there, I think we could safely call this the year of transforming the role of the RN in primary care. And so our goal today is to share some of what we've been involved in, some of what we've learned. I'm going to talk particularly about what we learned nationally in the LEAP project as we looked at exemplary or highly innovative practices, what we saw about teams in general, because we can't speak about the role of the RN in isolation and really have a meaningful impact, what we learned specifically about what people were doing, and then take it back with Mary talking about how this has played out in one albeit large, but one primary care practice, which represents many of the same challenges that you all are engaged in. So we're going to cover that whole spectrum. If we thought there were only one or two or three organizations that had transformed the role of the RN in primary care, I don't know if we'd be willing to go out on a national webinar and say this is the way it ought to be. But in fact, we are seeing enough around the country in common that we think there's now a body of knowledge which we can talk about. So before I jump into my section of the presentation, Mary, let me turn it over to you to just talk about our learning objectives for today.
Sure, perfect. So we have a few learning objectives for today's webinar. The first is just that participants will be able to name the ways in which nurses can be more fully utilized in improving outcomes for patients, be able to name elements of complex care management, as well as to identify some newly developed tools that are out there to support training the next generation of primary care nurses, as well as to support growth and development of complex care management skills in existing primary care nurses.
Perfect. Thank you, Mary. Peter did a great job of situating himself in Montana, so we'll give you just a few seconds on where we are situated. We are in Connecticut. As Peter said, we're a pretty large statewide federally qualified health center, but I think what's most important is to know that we have a highly integrated model, that RNs are part of our core primary care teams as well as our extended teams, as we'll describe, and that we're based really on three pillars in the organization: clinical excellence in everything that we do, but also research and development through the Weitzman Institute. And Mary, I hope you're going to talk a little bit about the research you're doing on the role of RNs in primary care. And then we're very engaged in training the next generation. You heard in the introductions about the work we're doing with postgraduate nurse practitioner residency programs, but I want to flag that we also developed a postgraduate licensed clinical psychology residency program, because if we want to train people to an integrated primary care model, the more of those folks we have engaged as trainees, the better we are. And Mary, I hope you're going to talk a little bit about what we're doing with training the next generation of RNs for primary care through the dedicated education unit. And we think all of that is important, but we don't need to say much more about the community health center. You could go to our website at www.chc1.com if you want to find out more. What you can tell perhaps from this slide is that we look a lot like many primary care practices that care in particular for vulnerable populations, that our patients are overwhelmingly challenged by low income. They are disproportionately uninsured, even in today's environment where we've lowered the percent of uninsured people. If they are insured, they're more likely to be insured by Medicaid, and they suffer from a wide variety of chronic illnesses, and these are patients who stand to derive enormous benefit from excellent primary care and primary care that delivers on the promise of responsive preventive care, health promotion, chronic illness management, and very timely and immediate access to acute care treatment when it's needed. In short, I think probably we look a lot like many of you. So let me pivot now to a little bit about the LEAP project. And I realized about 2 minutes ago that we never gave you an important website address on any of the slides, so I'm just going to say it now, and Mary, remind me, and I'll repeat it later. improvingprimarycare.org, if you haven't been to that website, is an outgrowth of some of this work of the LEAP project and has many tools and resources and videos that I think those of you on the call might find very helpful. But the LEAP project was really the brainchild of Dr. Mary Joan Ladin and Dr. Nancy Fishman at the Robert Wood Johnson Foundation, who said, we know that the evidence is very strong now, the research is very strong, that team-based care is more effective, more able to contribute to the triple aim and even the quadruple aim than care that's delivered without teams. We should really try and identify around the country what are the exemplary primary care practices in terms of a team-based approach to primary care. How do they make a difference? And then let's look at each element of work on the team to see what we can learn from that. And with that in mind, we set out first with a recommended sample using snowball techniques. of 300 practices across the United States and a research team that called them and talked about what they were doing in terms of team-based care, looked at some of their quality measures, looked at their staff compositions, and using a pretty rigorous approach, although rigorous qualitative approach, netted down to about 30 different practices. And I think it's important to note in terms of what we're going to focus on in terms of the role of primary care, as we learned in the LEAP project and as we're carrying it out here at CHC. This is not an East Coast phenomena versus a West, Southern, or Midwestern phenomena. It's not a large versus a small practice phenomena. It's not academic medical center versus community health center. But in fact, in the LEAP project, we saw all these kinds of practices pretty well distributed around the country. And in fact, we made it a priority to make sure that we were looking at different kinds of practices to see if all of this held true. So we netted down and identified our 30 exemplar practices. We made site visits to each and every one of them for a period of 3 days. A qualitative researcher, a clinical lead. I served as the clinical lead on visits to about 8 of them. And then an observer who helped document interactions between staff, patients, and each other. We collected lots of data on their innovations and their change processes, their quality improvement, and their best practices. And from that group of people, we also created a learning community who came together over the next 2 years and helped us further advance this work, further look at each role, further think about how they were making a contribution to primary care. And from all of that came the toolkit that I've just described to you, which you can find at www.improvingprimarycare.org. We've published one paper, have 2 more in publication about to come out, one of which will focus exclusively of the role of RNs in primary care. But here's what we found in general in terms of major findings from the site visits. And again, I'm going to stay at the level of the whole practice, not the individual RN element, for just a minute. One, we found that practices had very well developed what we called core teams. And these core teams always included a primary care provider. It could be nurse practitioners, could be PAs, could be physicians. And that primary care provider had a dedicated medical assistant in virtually all instances that formed a teamlet, and they had core RNs supporting the team as well. And then they were surrounded by an extended set of people and services. These could be RN care managers, and sometimes the RN incorporated, as we'll talk about, both the core team and the extended team functions. They often had pharmacists, which I have to say was a bit of a surprise to me, how widespread that innovation has been. And the majority had also taken the step of adding behavioral health specialists to that extended team that was there helping them manage their patients. They had in common that these sites performed planned care, where they knew as people were coming in what they were uniquely due for based on their age and gender and risk factors and particular chronic illness challenges, that they performed population management, where they looked at the panel as a whole and the practice as a whole, and that medication management, with or without a pharmacist, was a part of the work that they were doing. And the third finding was that lay people and people who manage what we call flow, and you all know what I mean by patient flow, but these individuals carry titles from office manager to care coordinator to patient service associate, but somebody was really looking out for how patients moved within the practice on a regular basis. And the lay people might also carry titles like coaches or health navigators. Now, I talked about the research that's been done, and we have a long bibliography that we didn't attach to this, but we certainly could post when these slides are posted, that show that using teams in primary care improve clinical outcomes, and they improve it both in the areas of prevention and health promotion, and they improve it in the area of chronic illness management. There's evidence to suggest that they improve the experience of the patient and that they provide better access through increasing the capacity of the team by having multiple people share the workload. There's evidence that primary care teams improve support for the most complex patients. Mary and I sometimes describe these as not the people who have diabetes or heart disease or depression or HIV, but the patient who has all of these and also maybe spent the night in a homeless shelter last night. Very complicated patients. We have evidence that primary care teams can reduce burnout, and we know that many people have gone in the direction of primary care teams in part of their search to be recognized as a patient-centered medical home. So before I go specifically into the role of RNs, then I want to summarize a little bit with, well, what is the key function of really excellent primary care? And as part of the LEAP process, we divided this into the before visit, the during the visit, and the in-between, what we call managing the space between the visits. And you can see how all of these would lead to the quadruple aim. Before the visit, better access, whether that's through things like same-day appointments, advanced access, or even implementing on-site urgent care or quick care, better communication through things like patient portals, and population management, knowing what the issues of concern are to the population as a whole. During the visit, that when the patient arrives, we are ready for them. We know what missed opportunities we may have had from earlier visits to catch them up on their health promotion and preventive measures or chronic illness measures, that we are addressing self-management, goal setting, and following up on self-management goals, that we're doing medication management, and that we have a way to connect them with behavioral health for support, hopefully right then in the same visit through a warm handoff or some other kind of same-day connection. And then in between that, we're managing their referrals, we're managing their connection to community resources for the things that are really beyond the domain of primary care for most of us: housing, food, transportation, fuel assistance, daycare, a whole range of issues that affect people's ability to live healthy lives, and doing some element of care management in between the visit, particularly for patients who are transitioning between levels of care, patients who are being admitted and then discharged from the hospital, or patients who are showing up in the emergency room. So with that as background, let me tell you a little bit about what we observed in these practices. First, about the role of the RN on the core team, and then the more extended functions as we think of the complex care management work that RNs are doing in primary care. First, empanelment underlies all of this, that if everybody's in charge of everybody all the time, it's the classic case of everybody doing everything means that nobody is really responsible for anything. Instead, RNs are responsible for specific panels of patients, one or two panels of patients. In a small practice, it may be for the whole practice, but that they know who their patients are. Two, that they take particular responsibility for leadership in the areas of prevention and health promotion and some of the routine chronic illness management. Three, that they carry their own schedule of visits and are accountable to that schedule of visits, also thereby increasing both access and capacity. Some of this is done under standing orders, some of it under delegated order sets, as Mary will describe a little bit more. They play a particular role in the supervision and leadership and training of other people on the team, particularly medical assistants, but also other nurses, and there may be additional care team members that they're responsible for. And of course, with all that RNs have taken on, they haven't given up an important role, which is providing advice and guidance, often telephonically, and providing triage, helping people get to the right level of care. And if we're doing things correctly in terms of advanced access and timely access to care, that triage function is not about convincing people that they don't need to come in, but rather helping make sure that they do get to the right level. Additional core team roles included following up on hospital admissions. In some practices, they were leading or co-leading groups from tobacco cessation to diabetes self-management groups. They were always involved in medication reconciliation. And in a few practices, though we did not see enough of this to consider this routine, they were also engaged in home visits. Then we looked at the issue of the RN care manager, more of the extended core team functions, and saw that rather than managing the whole panel, that this was about managing that subset of patients, people who rose to a level of complexity or multiple care providers engaged in their care that really needed particular focus. And I'm going to let Mary talk more about how we're doing that at the community health center, because this is a vital role that had not been previously well documented or well observed. The era of RN care managers calling it in, dialing it in from the insurance company was the norm for many years, pretty well shown not to work very well. That's been replaced with RNs in the practice doing complex care management, and I think we're going to see this as a very important element of the RN role in transforming care. We saw that people did this by standing order and protocol regularly, and as Mary's going to talk, and we have borrowed some of this language now, also this more unique element of what we call delegated order sets. Standing orders as applying to everybody with a particular condition all of the time versus the delegated order set, providers laying out a path for the RN to follow with a particular patient, particularly in the arena of chronic illness management over time, adding on to that education and support that the RN would typically do, the ability to actually manipulate based on how the patient was doing some of the treatment regimen. So with that, I'm going to stop here. That's how it looked to us across the country and across these 30 primary care practices, and we talked a lot about this at the Macy proceeding, and you'll read about it in some papers coming forth from the Macy conference in the form of written proceedings. But Mary, I'm turning it over to you to really talk about how does this work on the ground under your leadership here at CHC.
Perfect, great. Thank you so much, Margaret. So really, I just wanted to start kind of in general talking about the role of the nurse here at Community Health Center. And, really we use sort of this schematic even when we're recruiting for nurses to come to our health center, because again, most nurses, when they're trained, they're not really trained to a primary care model. They maybe have, one course in community nursing, and that may be really the entirety of their exposure to really what we do in primary care and really what the benefits are and what the role actually looks like. So again, really wanting to make sure that nurses understand that, a lot of their role is to promote access for patients, whether it's through triage and advice or whether it's through expanding services through independent nursing visits or expanding hours and evenings or Saturdays, et cetera. And that really what we're growing here is a growing group of nursing colleagues that are able to learn from each other and support patients on their journey to self-management. One thing that you absolutely need, obviously, in order to be successful with that is data. And I think as Margaret had alluded to, there are several challenges, when we think of our electronic health records. One of which really is that the measures within the electronic health records are really not designed to highlight the contribution of team members. And so you have to be very thoughtful about structured data fields and sort of entering certain amounts of data in different places, whether it's history of present illness or different sections in labs or other places where your team can actually have structured fields to document where you can measure. For a community health center, much like most health centers, we take our data out of our electronic health record and use sort of an export, transform, and load process to dump it all into a data warehouse every single day, every 24 hours. And we use that to be able to create our structured data pulls, our dashboards, and our scorecards. We really need to make sure that our teams have the right data at the right time so they can not only deliver individual patient services, but population management and really to be these proactive outreachers to recapture patients and deliver the appropriate services. So just to talk a little bit about CHC's interdisciplinary team and really our pod design, you'll see a picture at the bottom of the slide, and this is really your typical pod here at Community Health Center where, everyone has the same desk. You probably may not even be able to tell which people are the providers and which ones are the MAs or the nurses, but they all sit together really so that they can have this cross conversation and support to be able to better organize their day. So in our pod, we have 2 medical providers, could be a nurse practitioner, a physician's assistant, a physician, or a DO, with 1 registered nurse to support those 2 provider panels, as well as 2 medical assistants, so 1-to-1 staffing for medical assistant to medical provider, as well as 1 behavioral health clinician to really make sure that we are having full integration of behavioral health services. And then, of course, our other additional members, podiatry, dietitians, et cetera, and then our students and trainees, again, because if we are not dedicated to training this next generation, this model is not going to continue to spread as it should. Certainly one thing that we definitely hold true here at CHC is that it's very, very important to have a dedicated role, and we truly believe in the role of the Chief Nursing Officer here in primary care, and really support that in order to make sure that all of our nurses, our medical assistants, have support in terms of trainings, competencies, program oversight, and really elevating that role to the doctoral level to make sure that we are promoting research and translation and really supporting the work that they're doing every day, but that being sort of cutting edge and really thinking about this role and developing. You know, as much as Peter had mentioned that what the role of nursing may be, really this is what it is today here at CHC. So I would be remiss if I didn't mention for a moment the role of the medical assistant, because again, as we think about sort of that IOM report that says that nurses should practice at the top of their license, it is absolutely impossible to achieve that if you don't have every other member of the care team practicing at the top of their license or their certification or training. So I just want to mention, the role of the medical assistant briefly. And here at Community Health Center, the medical assistants really focus on doing the bulk of the planned care, whether it's point of contact or point of care testing for chronic illness, such as diabetes, or doing their routine cancer screenings, depression screenings, sexual orientation and gender identity data collection, et cetera. But they also lead the way in terms of panel management, looking for gaps in care, patients who have been lost to follow-up, uncontrolled diabetics who haven't been in within the last 3 months. They also are our diabetic retinal camera operators, and they, just like every other front care team member, is a part of our QI and microsystem participation to really make sure that as we are improving what we're doing at the front line, that it's really taking into consideration the thoughts and contributions of those who are actually doing the work every single day. So I just want to share one picture. This is actually of one of our dashboards specifically that our medical assistants use for panel management. Oftentimes you'll hear a lot of folks talking about morning huddles, and I think we really realized that medical assistants spend a significant amount of time sort of picking through different parts of the electronic health record to find the data that they need to for the huddle. And frankly, if it can be automatic, why not make it automatic? So we sort of call this our e-huddle or our electronic huddle that makes it so that the medical assistant can really pull up the dashboard for their patients coming in that day and really see what are the care items that they are due for. So as you see sort of the patient on the top screen or the top panel, you can see this is a 13-year-old male. They're here for their medical appointment. It was yesterday at 1 p.m. They had a dental visit back in August, so they're not actually due for their next dental visit yet. And what was the reason for the visit? So they're coming in, they have a sore throat, fever, and a headache. But then you can also see that there's other things that they're due for. They're actually a candidate for our fluoride varnish program. So maybe the medical assistant is going to support the dental hygienist coming in the room to apply fluoride varnish. They're due for their flu vaccine. They need some education, maybe about diet and exercise. They need a depression screening. We need to offer them HIV screening and actually collect sexual orientation and gender identity questions as well. Same thing for the second client. You'll see this patient actually is eligible for something that we call a WHO, which is a warm handoff to behavioral health, and we sort of have proactive and reactive warm handoffs. So occasionally the medical team will identify that a patient really needs the support of behavioral health today, and that could be the medical assistant, it could be the nurse, it could be the provider who identifies that and actually gets the behavioral health clinician in the room to have a face-to-face interaction, maybe just for 5 minutes, maybe they have time to do a full intake today, but really making that human connection so that follow-up can be planned. But for this, actually, these are our proactive warm handoffs. So these are patients who either have had a diagnosis, a mental health diagnosis on their problem list prior, maybe they're on a chronic opioid, or have scored on their PHQ-9 at an elevated level that we just want to, walk in, introduce ourselves, let them know that we have behavioral health services available, so that should they need or want to access services, they know that we're there for them. So moving into the role of the nurse, which is sort of what you've all been waiting for, to talk a little bit more about that at Community Health Center. So just a reminder, we are as one registered nurse to 2 primary care providers, and we're almost fully a BSN prepared registered nurse team at this point in time, really wanting to focus on sort of those elevated elements of complex care management that I'll talk about in a few moments, and really wanting those additional critical thinking skills that we think can be attained through completing a BSN degree. But our key activities is, of course, the nurses are supporting what the providers do every day. So their 2 providers will be scheduled with patients, and the providers may identify patients on their panel that the nurse needs to intervene on to really support throughout the day of the medical provider. But they also have their own schedules with staggered visits, both independent via standing order or independent based on a delegated provider order. With that, they're really focused on supporting self-management, goal setting, and care management for those patients. And then we sort of have a centralized triage group that also supports making sure that we have availability to give telephonic advice and triage information to patients, but without having to sort of pull from the patients who are here in our office today. So pulling from our staff, so making it central in our call center. Much like our medical assistants, our nurses are quality improvement leaders. They're quality improvement coaches. They participate on the teams. They give lots of feedback. Our nurses and our nurse managers do participate in research. A few of them have participated in supporting what I'll talk about in a few moments with our dedicated education unit as well. So really lots of opportunities for growth and development. Certainly we want to support their one-to-one interaction with their patients, whether it be over the telephone or in person. But again, being a nurse is so much more than that, and we want to make sure that we're supporting at every step. When I talk about standing orders, I just listed here a few examples of some of the ones that we have at our health center. So for example, if you're an 18-year-old woman coming in with an uncomplicated UTI, you can actually get an appointment with a nurse, and that visit can be completed start to finish by that nurse with the initiation of a prescription by standing order to that patient. Certainly, if support is needed from the provider because something comes up in the visit, certainly the nurse knows how to sort of include her team members to be able to identify and make sure that that patient is well taken care of. Another one that I'll highlight is our newest standing order, which is our asthma well care standing order, which includes spirometry, as well as completing those pesky med authorization forms and really supporting getting asthma action plans done and every element that could potentially be done for patients to really ensure that they are well in terms of their asthma. But these are many other examples here. Want to talk just a quick minute about our independent nursing visits. This is data back from sort of our last fiscal year, or the prior one. I'm sort of plowing through the data for this past one. But in 2014 to 2015, we completed about almost 21,000 independent nursing visits with a total of almost 29,000 different services delivered. So what that means is some of those visits, obviously, there may be more than one service that's delivered at that nursing visit. Of course, many of them related to immunization and screening. Maybe they're here for vaccines or STD screening or whatever, but as you can see, 4,200 really related to chronic illness care. Another column I wanted to really highlight is 5,400 related to chronic pain support and follow-up. You know, really recognizing this huge problem of opioid medication and pain management and just the support that patients need to really understand, given our multimodal approach to chronic pain, how to juggle all the different aspects, as well as, of course, anticoagulation management and nursing visits for standing orders really being a chunk of those as well. When we kind of break down sort of the chronic illness visits, of course, you know, no surprise here, the majority hypertension, diabetes, but huge portion of behavioral health as well as asthma and COPD. So really, I think the most exciting and innovative work that we've been doing is really around the role of the nurse in complex care management. And really, this has been focused on how do we make sure that nurses have the support that they need to be successful. So we have designed a number of tools, a dashboard, a scorecard, structured templates in our EHR, our standing orders. We've given all of our nurses facilitation training to even sort of teach them how to conduct meetings and how to support conversation and communication with the patients and their families, as well as our 2 innovations that I'll be talking about in just a moment, our Project Echo Complex Care Management and our dedicated education unit, with a huge focus to support nurses towards taking on this competency of complex care management. The goal of our complex care management program obviously is to improve quality and the coordination of care delivered to our most complex patients. We identify them using our dashboards, either because they're a recent hospital admit, maybe they're a high ED utilizer, or they have a chronic illness that's either uncontrolled or multiple, as Margaret had pointed out, 4+. Or potentially even a care team member could identify them. All of our patients, we attempt to consent them to be a part of care management. Namely, obviously, if they're a Medicare member, we want to make sure that we're able to bill for this service and send a strong message to Medicare that these services are important, that they're valuable, and that they should be compensated to really show the work that our nurses are doing every single day. But also really to make sure that the patient is a full member on the care management team, that they are agreeing and sort of consenting to be a member and to be activated as part of that sort of teamlet to accomplish the goal of self-management. Of course, our essential elements, transition care, medication reconciliation, and again, not just looking for sort of, what are the outliers or the things that, are on this med list but not on that med list, but really taking it to the next level and making sure that nurses are able to identify, this is not the correct beta blocker to be on if you are a congestive heart failure patient, or gee, you're COPD gold stage 3, you should really be on this type of a regimen, and being empowered as a leader to be able to give that feedback to the primary care providers to really make sure that those medication changes are happening. Creating individualized care plans and then adjusting and treating regimens. And then, of course, knowing at what point we can really discharge from the program. As I mentioned before, our facilitation training, 32 of our nurses to date are trained, and we're implementing to make sure that every new nurse that comes into our health center is really trained to be able to promote sort of her leadership, her communication skills, and the ability to be able to bring groups of people together and to create change. Just want to show you one of our dashboards. So this is how our nurses really will identify our complex care management patients. So you'll see here, this is just one section of it. So we look at ER utilization, hospital admissions within the last 12 months, red signifying that it's within the last 30 days, as well as uncontrolled chronic illness. And you can see here in each one of the columns, you really want to make sure that your data, that your nurses are able to sort it, that they're able to really figure out who do they need to proactively outreach to today. So certainly you have different sources of data. For us, we actually collaborate with our external Connecticut State Medicaid. We share their claims data so that we're able to identify patients even sooner than the hospital documents actually are received into our dashboard. And as you can see, those nurses are able to sort it so they can really see who are the patients that I need to outreach today to make sure that I'm making the biggest impact, and really so that they can look at trends of admission and other things over time. We also have scorecards, and I'm just going to show a few sections of the scorecards today. First, really looking at total enrollment over time, and really why this information is really important is you want to make sure that nurses are continuing to enroll, right? So we want to make sure that new patients are coming into care management, as well as that patients are being discharged, that nurses really understand at what point we admit and at what point we discharge from our program. So you can see here as a manager, or even as a chief nursing officer, I'm able to look here and to be able to see, patients continuing to come on and to identify nurses who may be struggling to really have uptake to our model. And then we sort of look at enrollment to date to really identify how many patients can our nurses really manage at any one given time. And we really have a strong range. The two lines on the bottom actually combine. This is a nurse that's split between two sites, but really looking anywhere from 30 to 60 to 70 patients that our nurses are really able to manage sort of over time. But again, continually admitting and discharging in the program, so there's always movement in the panel. I sort of bring this up just as an example to see in our scorecard, again, we are beginning to hold our nurses accountable for some of these measures that we typically only would hold a provider accountable for. So a hypertension control rate or a diabetes control rate. Why wouldn't you hold the nurses accountable? They are able to proactively outreach, they are able to complete independent standing order visits with these patients, and they're able to really do an amazing barriers assessment and really get to the bottom of a lot of those barriers, collecting that data, working directly with the primary care provider. So this particular example on the top, you'll see the top bolded line is actually the nurses' combined data. But if you look at the two individual, these are the two different provider panels that she had. So what you'll see is that actually the top provider is performing quite well. Their hypertension control rate, 78.1%, I believe, or 78%, and then the provider below that, 61.1%. So again, what this does is it allows your nurses to be able to think about allocation of resources, right? So they can look and identify panels that may be struggling, and then also really identify like strong practice to be able to say, what am I doing with my other provider that's working really well, that's getting us to control, that I can really bring to and apply to my practice with the panel of patients for the other provider. So that's just an example of our scorecard. But again, in order to really get there, the main problem statement that supports everything that we do in care management is that, patients continue to increase in complexity. They require significant support. Primary care nurses really are key players, but they really need expanded, support to be able to help them to grow into this role, as well as to enhance their content knowledge, enhance their leadership identity in the overall care team, and then to really help them to collaborate better internally and externally. So Project ECHO is really where that happens. And really just to talk briefly, the Project ECHO model, I'm sure many of you on the line are familiar with this. This is really a provider-centric model of knowledge transfer that really supports primary care providers to learn how to manage specialty diseases right here within their four walls. This is from Sanjeev Arora, Dr. Sanjeev Arora out of the University of New Mexico, who really started this first with hepatitis C. These patients were having to travel 2 and 3 hours to get to the educational center, and frankly, they just weren't going. And they had much better rapport with their primary care providers. So he created this model where he could use telemedicine and video conferencing to support these providers by giving them didactic and then also allowing them to present their own cases to give them feedback and support. So with that, we took that model and sort of picked up the provider and said, can we put nurses into this model and use it to really increase knowledge, increase confidence in these nurses, and really increase their ability to function as care managers. So our complex care management program, again, has all of these goals. We want to increase their access to a diverse faculty expertise that can really support what they're doing, improve their leadership and their confidence, and really help them to collaborate better with external and internal agencies. Our first session was on September 24th, 2015. It's 2 hours in length, and we have 2 sessions per month. We have one didactic that lasts about 30 minutes, and then the other hour and a half is really dedicated to allowing our nurses to be able to present their cases for feedback and support from the multidisciplinary faculty. And you'll see a list of the faculty here, everything ranging from a medical provider, a behavioral health provider, home care nurse, pharmacist, pretty much everything that you would really need to give input to be able to really manage our most complex patients. So when our nurses feel frustrated and feel like they're bumping up against a brick wall and they're not sure what to do next, they have a faculty to depend on to support what they're doing. We have a case presentation form so the nurses can sort of organize themselves to really better define what are the questions that I'm having about this patient that I'm having a difficult time answering. So to date, since from September to July 2016, all 12 of our sites have been involved. We have 35 nurses who have been involved and 19 ECHO sessions at that point in time, really that have included 42 case presentations, 35 of which have been unique patients. And some of our nurses, you can see uptake looks a little bit different, but about 66% of our nurses have already presented. Now we're up to about 80% to date. But some of our nurses, we have 4 nurses who have presented 2 cases, and even 1 nurse that has presented 8 cases because she really has a very complex panel and has been very involved with just sort of the success of our care management program. These are just some of the didactics that we've had, up until that sort of July point, making sure that the nurses have support in better understanding medical nutrition, counseling, diabetes disease management, how to better utilize their relationship with a visiting nurse, and really looking to continue to support this curriculum to head and align with sort of the AAACN certification for care management. We also, of course, again, we certainly train and support nurses who are transitioning into primary care with very limited experience from their academic experience or maybe even from their prior professional life. But again, we're not satisfied with just doing that. We want to make sure that we are making a hefty contribution to training the next generation and really giving voice to how we think nursing education needs to change in the future. So with that, we've partnered with Quinnipiac University here in the state of Connecticut. And in January, this past January, we took on our first 16 senior level BSN students who came to our health center for a dedicated education unit right here in primary care. And really, of course, as you know, this is related to the model that came out of South Australia from Flinter University, really making sure that nurses have that one-on-one with a frontline staff nurse to get that support and training, as well as making sure that we're facilitating peer learning. These nursing students also get to participate in our ECHO sessions and have preceptor time to do these independent nursing visits. And really for them, it's a huge shift in thinking. The way that you think about managing a patient in the hospital versus managing a patient here in primary care looks very, very different. And the skill set is very different with a heavy weight on that communication and goal setting and coaching and all of those things that you really need to motivate a patient to change. These are just some of the pictures of our DEU students that had recently wrapped up. And, I'm proud to say that, the first 8 that even went through the program, they enjoyed Project ECHO so much that they even presented a poster at one of our local Connecticut Association of Public Health Student Nursing Workforce Development conferences. And they just did an incredible job with that. I sort of finish here just by adding in some of the statements that our DEU students have made, just thinking about how ECHO and how their experiences here in primary care really shaped what they're going to be doing now as nurses moving to the front line, whether it's in primary care or whether it's in the ICU or the ER, knowing that those patients are coming back to primary care and understanding that side of the continuum. So with that, we say thank you. And Margaret, I'll.
Yes, I stand in amazement at Mary's ability to deliver a 2-hour presentation in 30 minutes, but you managed to complete it and have time for questions. So let us turn it back over to Peter and Christine.
Thank you so much. We appreciate the presentation. As I mentioned before, we have a little bit of time left, excuse me, for questions. So if you use the questions toolbar for your GoToWebinar application and log your question there, try to be as concise and clear as possible so we can deliver the question appropriately. So we've got a few logged already. There are a couple of clarification questions, and I'm assuming, ladies, I'll be able to post these slides after the presentation?
Absolutely, yes.
Okay, great. And then I have another clarifying question here. So please clarify if the nurse is documenting medication compliance with their medication regimen versus reconciling the medication list.
Absolutely doing both of those things. They are information collectors, and then of course they report that information back to the primary care provider who may need to make adjustments to the regimen. But really, that's a huge amount of information. If we're doing a transitions of care and that patient is reporting that they're not taking their Lasix, the nurse absolutely will document that in the electronic health record and forward that on to the provider, who obviously needs to be involved because we want to make sure that we're preventing readmission for that patient.
One more question. I think you're going to say the website address again for us. People asking about what the website address was.
Sure. So there's two. One is the Community Health Center website address is www.chc1.com. But the website for the LEAP project, which has a lot of these tools on it, is improvingprimarycare.org. And I really want to give a shout out to my colleagues from the LEAP project at the McCall Center, which has really led the development of the website and made it a living, breathing tool to which they are constantly harvesting tools from the learning community and adding, because we know for a lot of people, the infrastructure around this is where, we just trip up. Do you have to write new job descriptions for everybody? Do you have to develop your own playbook? Do you have to have your own protocol and standing order? And so the LEAP project has really tried to collect a lot of those tools, not that you can just adopt them wholesale, but you can use them to hopefully make things easier for you to make those transformations.
Great. I have another question. Can nurses bill and be reimbursed for their services in Connecticut?
That is a great question, and we have to look at it by payers. I'm really happy to say that we have a very progressive Medicaid program in Connecticut, and we had many conversations over many years about this, but it was clarified that in federally qualified health centers anyway, I believe this is true beyond F2HC, so that RNs are considered allied health providers and can bill for their services. If you look at the private payers, most of them recognize services provided by RNs under the nurse visit designation, the old 99211, which I always say is a little bit unfortunate because it assumes that if a nurse did it, it was simple, easy, and quick. And we know that these things are anything but simple, easy, and quick. But that is one of the codes that you can bill under for services delivered by a nurse. And then what we see is really, I think, beginning to be exciting is what we see with Medicare in terms of being able to bill the complex care management codes, the wellness visits, and I think we're about to see a transformation in this whole area.
Okay, great. I have another one here. How do nurses balance complex care management with all their other responsibilities? Are they still doing triage? Is there time off of the care team to do this work?
That's a great question, and something that we've definitely struggled with over time. First in terms of the sort of the triage portion of the question, the majority of our triage really is handled out of a call center. So I have 3 dedicated triage nurses that really manage the bulk of the triage phone calls. Occasionally there will be an overflow one that may have to bump to a staff nurse, but we have sort of notification ways where we can send it out to a larger group so that someone who maybe isn't in a nursing visit or isn't drawing up vaccines or other things, are able to do that. Because remember, our nurses here in the state of Connecticut have to do all medication administration because our medical assistants do not have that.
We're enlightened in some ways.
We're enlightened in some ways and not in others. So our nurses are definitely very busy with medication administration as well. So certainly offloading triage was one of the biggest factors in sort of employee satisfaction for our nurses over the course of the last few years, and has really sort of freed them up to be available to the patients who are right here in our office. But we also do, first thing in the morning, our nurse schedules are actually blocked for 40 minutes, so they can actually go to their care coordination dashboard and really see if any new admissions have sort of hit that dashboard, so that they can really sort of plan for their day. But again, oftentimes, there may be no-shows or other things. So there is dedicated time in between, but really our nurses are very good at sort of being able to juggle. It certainly is a challenge, but I will say, a lot of people unfortunately don't think that primary care is that technical of a nursing job, but I would absolutely argue the opposite, that these nurses are highly skilled jugglers, and the way that they are able to move seamlessly from sort of one project to another is amazing. And so again, we specifically hire for that, looking for that, and really train to that.
Mary, if I could just add to that, some of these questions really, people have to go back to their office and look at their own size, right? Because some of this is definitely size related. We did not have dedicated triage nurses until quite recently, actually, and we get 1 million phone calls a year. So that it took us a long time to get to that. But we realized the constant interruption was very difficult for the nursing staff to carry out their work, but it was really difficult for the patient to get the response that they needed. And so there is a certain size threshold I think people have to figure out for themselves of when it is more productive, more satisfying, and contributes more to total quality to have a dedicated RN. One factor that hasn't been size related for us, I just want to highlight quickly, is the issue of, do you have separate core team RNs and RN care managers, or is it one person doing both roles? We are obviously plenty big enough to separate them into separate people. But Mary's RN team really lobbied hard, and we have tried to accommodate this, that they felt they should be the ones who did both the team core RN functions and the complex care management, because they knew the patients the best. They were the ones who were seeing patients when they were coming in during the routine times and when they were sick, and therefore, if they tripped into the category of being complex or having been in the hospital, they wanted to provide those services, and that's why we have taken on staffing up 1 full-time RN for every 2 primary care providers, although probably the nurses would tell us we should do 1-to-1, but we're not, we're not there yet. So that was not a size decision for us. That's really been listening and taking the feedback from our own nursing staff.
Great. I'm going to slide one last question in here, and then we may have time for one more, but I think probably just this last one. Is there an education or certification requirement for your nurses, and do you hire new graduates?
There isn't a certification requirement, although certainly I heavily encourage them that, especially now with our didactics with Project ECHO, and because we're really heavily sort of leaning towards the AAACN, for example, 48 hours of CNE, now that we're accredited by ANCC, really could contribute towards the total of 50 that would allow them to be able to achieve their certification. But
as certification as what?
As care coordinator.
As care coordinators, yeah.
But certainly, we do have some nurses who are CDEs and whatever, but we really don't require sort of any special certifications, and we absolutely hire new grads. I think new grads oftentimes are sort of the most excited, the most, very mission-driven. We're sort of moving away from the time where, to be a real nurse, you had to go to the hospital first, and so people are really passionate about primary care, and, maybe they know somewhere down the line they want to become a primary care nurse practitioner, and really learning how to be a primary care nurse first will really also contribute to that. And again, whether you're coming out of the hospital or whether you're coming as a new grad, I'm still spending 6 to 9 months to really orient you truly and fully to the role of a primary care nurse. So
which is why the dedicated education unit is so important.
Great, thank you so much. I'm going to flip it to Peter now to wrap us up with an announcement about next month's webinar. The questions we didn't get to, the presenters have been kind enough to list their contact information, so if you want to chat with them afterwards, I'm sure they're happy to take emails. Peter?
Thanks, Christy. And first, Margaret and Mary, thank you for a very wonderful webinar. Amazing. I wish we had 2 hours instead of just the brief time that we did. Secondly, I want to thank you for the example of national leadership that you've both provided for nurses, for interprofessional care, and for the transformation of primary care. So thank you for that. And finally, on December 13th at 2 o'clock, we will have our final webinar on primary care in the U.S. with the nursing workforce, and we'll focus in on the challenges facing nursing educators, and we'll provide an example of how that curriculum looks in a nursing education setting that has taken on those challenges and have revised the curriculum to produce the RNs that can work with Margaret and Mary in Connecticut. So thanks, and we look forward to hearing from you back in a couple of weeks.
Great. Thank you, everybody.
Thank you.
Great. Thanks, everyone.